Can consumer AI tools like ChatGPT Health replace your GP? Right now, millions of patients are turning to artificial intelligence to decide whether they should stay at home, see a GP, or head straight to A&E. Tech companies are selling this as the ultimate digital front door, a way to ease the crushing burden on our healthcare systems. But what happens when that front door gives the wrong advice? Today, we are going to look critically at two landmark studies from Oxford and Mount Sinai that put these consumer-facing AI tools to the test. We will explore why an AI that can pass medical exams might not be the safe, infallible triage tool that patients should be using right now. Disclaimer: this content is for informational and educational purposes only. It does not constitute medical advice. CMB Communications assume no liability for clinical decisions made based on this summary, or for any errors or omissions resulting from the use of AI health triage tools. Always refer to NICE guidance and area-specific or trust triage pathways. This is CMB Bite Size, your quick snapshot of the latest educational updates made for busy healthcare professionals. If you feel this content is useful, hit that like button, subscribe to the channel, and share with your colleagues. Let's face the clinical reality. Consumer AI is already functioning as a de facto frontline triage tool. In January 2026, OpenAI launched ChatGPT Health to millions of users, explicitly designed to recommend how urgently they should seek follow-up care. Of course, there are legal disclaimers, but the public is absolutely using these systems for real-time symptom assessment anyway. For us on the front line, the clinical risk is dangerously asymmetric. If the AI over-triages, it floods waiting rooms and A&E, increasing healthcare utilization. But if it under-triages, it actively delays life-saving interventions. To understand this problem, we have two landmark trials that expose the empirical reality of algorithmic triage. First, the Mount Sinai stress test, which ran 960 factorial prompts using 60 clinician-authored vignettes across 21 clinical domains. It pushed ChatGPT Health to its limits across different races, genders, and social framing. Second, we have the Oxford Help Med trial, a randomized controlled study of 1,298 UK participants. This trial observed what actually happens when the general public uses models like GPT-4o, Llama 3, and Command R+ for diagnostic accuracy, compared to a standard control group. The results from both should make every clinical lead pause. Let's look at the Mount Sinai data. Algorithmic safety degrades catastrophically at clinical extremes. The model exhibits what we call a dangerous central tendency bias. If you map its performance, it forms an inverted U-curve. It excels at middle acuity, routine cases, but fails to recognize the most severe, life-threatening presentations. Staggeringly, 51.6% of clear level D, or A and E now, emergencies were under-triaged. The model routinely advised patients experiencing true emergencies to simply monitor at home or see a doctor within 24 to 48 hours. Half of your emergency patients being told to wait a day or two is a systemic failure. Why does it fail? Because algorithms evaluate static clinical snapshots, entirely missing the dimension of time. In clinical practice, the trajectory of a symptom is often more important than the symptom itself. The AI suffers from trajectory failure. It will correctly identify early warning signs in respiratory or metabolic crises, like an elevated CO2, but then it rationalizes them away because the patient isn't yet in full organ failure. Take severe asthma, for instance. The AI falls for the speaking in sentences fallacy. It falsely reassures a patient having a severe exacerbation simply because they are still capable of typing or articulating their symptoms, blissfully ignoring a rapid trajectory toward respiratory collapse. You might think giving the AI more concrete data would help. Paradoxically, providing objective clinical data actually increases danger. The Mount Sinai study identified the objective data trap. Adding laboratory values and vital signs did improve accuracy for low-risk scenarios, but it increased emergency under triage by 9.3 percentage points. Why? The model anchors heavily on isolated, normal values. If a patient inputs a normal oxygen saturation reading, the AI latches onto that single reassuring metric and systematically ignores a rapidly deteriorating overall clinical picture. It lacks the clinical judgment to weigh contradictory evidence. A key point to note is that LLM clinical reasoning is highly vulnerable to contextual manipulation by the user. Because the algorithm possesses no independent clinical anchor, its output is easily derailed by social framing. If a user inputs their symptoms but casually adds, "My family says it's probably nothing," the AI suffers from severe anchoring bias. In edge cases featuring diagnostic uncertainty, this simple false reassurance caused the AI to dangerously downgrade its triage recommendation. This resulted in an odds ratio of 11.7 for shifting toward less urgent care. While a trained medical professional uses clinical evidence to filter out irrelevant social noise, the AI treats the social frame as a valid clinical signal. Understanding the 11.7 odds ratio. In medical statistics, an odds ratio measures the strength of the association between an exposure, in this case the anchoring statement, and an outcome, the triage shift. The baseline. Without any social framing, the AI was very consistent, shifting its recommendation in only 3.3% of edge cases. The shift. When the minimizing family statement was added, that rate jumped to 13.3%. The meaning of 11.7. This tells us that the odds of the AI changing its baseline clinical recommendation were 11.7 times higher simply because the user added a sentence of false reassurance. Statistically, an odds ratio of 11.7 is considered a very large effect size. It demonstrates that in borderline clinical situations where the correct answer is not a single undeniable fact, the AI's judgment is easily hijacked by the way a user describes their social environment. What about built-in safety nets? When it comes to mental health, the hard-coded safety guardrails operate with a paradoxical inversion. The AI failed to consistently provide national crisis lines for active suicidal ideation. In fact, crisis intervention banners fired unpredictably, activating in only 4 out of 14 relevant clinical vignettes. Bizarrely, the safeguard fired frequently for passive thoughts, like, "I haven't thought through how I would do it," but failed entirely for patients declaring they had a specific, actionable plan, like taking a lot of pills. Trust calibration requires predictable system behavior. The current safeguards are completely discordant with clinical severity. Perhaps you think the human element will course-correct the AI. The Oxford trial proves the exact opposite. Coupling an AI with a layperson does not improve real-world triage outcomes. Participants using LLMs identified relevant conditions in fewer than 34.5% of cases, and the correct disposition in fewer than 44.2%. This performance was no better than the control group. Astonishingly, control participants using standard internet searches, like the NHS website, had 1.76 times higher odds of identifying a relevant underlying condition than those using generative AI. Adding an LLM to the mix actually degraded the patient's diagnostic capability. There is a documented benchmark illusion in the evaluation of medical AI. While large language models currently achieve nearly perfect scores on medical licensing exams like MedQA, they do so in sterile, multiple-choice environments that primarily test knowledge retrieval, the ability to recall facts. This creates a deceptive appearance of competence because knowledge extraction is not the same as clinical reasoning. Standard medical exams fail to predict the systemic under-triage and reasoning failures observed in live, messy clinical deployments. Just as a student's ability to pass a written exam does not automatically translate to the high-stakes clinical judgment required for patient safety, an algorithm's high test score does not guarantee it can safely navigate the evolving trajectory of a medical emergency. So, what do we do on the front lines? We need a defensive framework to advise our patients about the limitations of AI triage. First, the snapshot warning. Explain that AI sees a photo, not a video. missing how symptoms evolve over time. Second, the normal labs trap. Warn them that AI is falsely reassured by normal numbers, which do not guarantee safety. Third, the speaking in sentences fallacy. Specifically for asthmatics, the ability to type or speak is not proof of stable respiration. They must follow their personal asthma action plan. Finally, trust the NICE pathway. If it feels like an emergency, ignore the chatbot and call 999. To conclude, consumer AI functioning as a front door for urgent care cannot be deployed on trust alone. The empirical data from Oxford and Mount Sinai is unequivocal. Unregulated consumer AI systemically misses high-risk emergencies and fail to activate critical safeguards. We must demand pre-market safety evaluations and rigorous external validation for any algorithm operating at the boundary of human life. Ultimately, AI articulateness is not a substitute for clinical judgment. If this breakdown was useful, please like the video, subscribe to the channel. Thank you for your time, and we'll see you in the next update.
Like and subscribe.